Over to you, David.
Thank you very much, Jennifer. And so I put the Twitter handles up there, actually. So just by way of introduction, in fact, I also want you all to do a little bit of activism, actually. It would take you about a millisecond to work out where I work, okay? But so I'm just emphasizing I'm speaking in a personal capacity. But obviously I do work in 2 hospitals in Birmingham, one very large one, which is very next to the University of Birmingham. I think we know its name. And also one in the west of Birmingham in the kind of West Bromwich area. I think we know its name. But my reason for being so obtuse here a little bit is I just find it very irritating, actually throughout the pandemic, is being the national comms policy, which I will explain to you. And I'll explain to you by a little joke I'm playing at the moment. If you go to my Twitter feed, I've actually pinned this tweet, and I am actually doing this. So any journalist that comes to speak to me, I ask them to approach my employer to look at this tweet, which says that the NHS national comms policy on the pandemic is insane. My employer will then say, I'm sorry, he can't speak to you. I need to direct this up to NHS England, who of course will say, no comment, hence proving that the policy is insane, okay? Yeah. My serious point for making this is that it's actually really, really frustrating for journalists reporting this story. And I actually think it's a big mistake because actually, you know, people in Bromsgrove don't really give a monkey what's happening in Brixton, but they do care what's happening in Bromsgrove. And actually people need to understand their own area and their own risk, particularly in the pandemic. And in a sense, the taxpayer pays for me, you know, and I think the taxpayer's got a right to know why medicine's changed so much and why we're expecting the public to do a really, really difficult thing. And it is a really, really difficult thing that we're going through at the moment. So that's by kind of way of introduction. So if you want to retweet that pinned tweet, or actually if you want to contact your MP and think, this is disgraceful, why can't, and all I'm asking is that actually NHS hospitals have got trust communications departments that can speak to local journalists. And I'm just asking that NHS trust departments can actually answer these queries, because it actually plays into the people that think the pandemic is all fake news. And we might go on to that, but and actually it's really unhelpful. So I think you guys need to understand what's happening in your local area, because that actually helps you understand the risk. That's a minor rant at the beginning. And we're going to start this. I mean, I can't believe we did this a month ago. I've been doing these, I think, Jennifer, I've been doing these since April. And I think this is definitely my low mood one. I suspect that reflects the country's low mood, but I'll explain a little bit. But I think part of the problem is almost dealing with uncertainty. And actually, it's very difficult, I think, psychologically dealing with the uncertainties of a pandemic. And we did this the last time, and I think we're going to do it again, actually. The things we got wrong, and actually just on a reflection, what did we get wrong? I'm sort of thinking about this. There was a paper in the BMJ a few months ago, and it got a lot of us thinking. And I think actually there's not enough people that have been able to look back and say what they got wrong. Now, in fact, this was the first one back in April. It was in the Bromsgrove Standard, 17th of April, saying we needed more testing. Well, okay, we got lots of more testing, but the one thing we haven't got is the support. And you know, I think it's very, very difficult if you're self-employed plumber and you get COVID symptoms and your family's relying on you, what level of support there is for you to properly isolate. And that's still a problem today. And I have to say, on this, I think I was right, talking about greater border security. It seems unbelievable that we've had such a toxic referendum about Brexit and borders and everything like that. And most of the last year we spent worrying about, you know, a few asylum seekers and dinghies, but not worrying about the 20 million people coming through airports. Was a fairly important public health measure, basically. We didn't actually protect our borders. But the reason I was saying this about people reflecting, this was some work that a cardiologist has done, looking at the doctor optimistics, shall we say, who've kept us going through the pandemic, saying that, you know, everything's going to be better. My particular favorite was Professor Carol Sikora. He's got absolutely no experience of COVID. Okay, I don't think he's ever seen a patient with COVID. He's an oncologist. Okay, but throughout has said, you know, it's all going to be fine. It's extremely encouraging. When I pointed out that he's got actually no experience of COVID, he blocked me. And I think this has been a problem in the media, actually. I mean, I suppose it's difficult because there's not many science journalists, but, you know, actually false hope is not a useful way to manage a pandemic. No, this sounds very down because actually there's a lot of hopeful things. I mean, if you told me back in April we're going to have free vaccines in January this year, I would have said you're crazy. Okay, so you know the vaccines are the real hope out of this, but it's not just Sikora, a whole bunch of other people. I mean, it's quite useful exercise. But I think science will look back on those people that wrote signed the Great Barrington Declaration as some of the stupidest bunch of muppets that ever had a science degree, to be quite honest. You know, the idea that we could just infect the population with herd immunity and would ever be all right was just, I mean, I'm not the microbiologist, and as the speaker, I'm sure Willem will come on to this, but you know, the way you get herd immunity from a virus is by a vaccine. And that's where we're going to go, basically. And it's interesting today, Toby Young, who you may know, is often on, you know, Question Time, writes in The Spectator. Surprise, he's been deleting his tweets, saying that, you know, this was all, you know, he sets up the lockdown skeptics. And I've got absolutely no doubt that actually many people have actually died because of some of the false optimism spread by these people. So anyway, that's if you, Dominic Pimento collected this. Not surprisingly, quite a few of them have blocked him because they didn't like being called out on some of the stuff they did. Now, I've showed this many times before. This was my ward back in March in the first wave. We did a lot of work looking at hospital-acquired COVID. Gosh, how things have changed, okay? You know, it really has changed quite dramatically, and I would say it's changing literally every day. So this was back in March. In the summer, you see Bay 1 on the right, that we changed into a red area for any suspected COVID patients, but obviously the number of cases just plummeted in the summer. And essentially about a week ago, that is now all red. That's not, it was never a COVID ward, now it is a COVID ward. And that's just an indication of just how much things have changed. So where next? Well, just in time, we talked about this in terms of logistics and Brexit, but actually just in time logistics is so important with vaccines. Maybe that'll come out in questions, but you know, the whole vaccine program is the single most important thing, really, that we've got to get out. Is basically get as many people vaccinated as possible. May come up with questions, the debate about the timing of the second vaccine, that kind of thing. I'll allow that for later on, basically. But this is where we're at, data from this week, and that is not a pretty graph, okay? You know, number of cases going up significantly, and we are definitely, this is, you know, I'm speaking for every doctor I've spoken to, and this is significantly worse than it was in the first wave, basically. Ironically, I can remember saying back in April, when we were talking about the 1918 Spanish flu, how the second wave was the worst. Well, we're definitely in the second wave. And you can see just Sandwell and Birmingham, you know, the number of cases, how they've gone up. I'm going to skip for time there, but I'm going to swap over to Willem. You may well show some slides just in terms of the sequencing side of things.
Yeah, okay, thanks, David. Let me see how I can share my screen.
But please ask questions, chip in.
Oh, sorry. Can you see this, or do you see my?
Yeah, just make it bigger.
Yeah, we can see that.
Yeah. Right. So my name is Willem van Schaik. I'm professor of microbiology and infection at the University of Birmingham. So put up my Twitter handle there, and I've been sort of concerned about COVID for a very long time. So sorry, this is oops. So this is from March 2020, when I really couldn't help myself anymore and had to speak up when the government was still letting the Cheltenham Festival go ahead and all those things that happened since then. And we discussed this only a month ago, David and I, that one I wanted to leave on a positive note, because that's one the first papers came out which described, in this case, the Pfizer vaccine and how incredibly well it seemed to protect against COVID-19. And David already alluded to it. I completely agree that, let's say, the vaccines are now definitely our best hope to get out of this. But since then, of course, other things have happened, and I'm basically on the in terms of the evolution of the virus, and I'm just going to spend 2 slides on that. So because I'm sure you've all seen figures like this one here on the left, which is a schematic representation of coronaviruses, or SARS-CoV-2, the virus that causes COVID-19. And viruses in general have once been called, this is from Professor Peter Medawar, who was in the 1950s for a few years professor of zoology at the University of Birmingham. And he very astutely described viruses as a piece of bad news wrapped in protein. These are not technically alive. They're very simple things, generally, viruses. And I'm going to give you just one slide with sort of a background of the biology of these type of coronaviruses. So all viruses have genetic material in them, which codes for example, for these proteins that they put on the outside, these spikes that we, of course, hear so much about. And viruses can use either DNA or RNA as genetic material. And you can forget about those acronyms almost immediately, but the thing that I sort of would want you to remember is that RNA viruses have a tendency to mutate more than other viruses, because RNA is inherently more unstable than DNA. And so we know that, generally speaking, coronaviruses do not mutate that quickly. So influenza virus is another RNA virus, and it mutates very quickly, and that's why we need to change the flu vaccine every year. And we're pretty good at doing that and preparing flu vaccine. And so over the course of 2020, new mutations in SARS-CoV-2 had been described, but none of them had a very clear impact. And of course, that changed about a few days after we had our webinar in December, when the first description of what was then called the variant of concern 2012-01, or also called lineage B117. I'm sorry for these names, but which is now sort of internationally widely known as the British variant. And we can argue whether that name is correct or not, but at least also my family and friends in the Netherlands and other European countries, everybody's calling this the British variant right now. And the reason for that is that it was first detected in the southeast of England. And so this is sort of a family tree of coronaviruses or SARS-CoV-2. And here on the top, you see the normal variation that you see in these viruses. And then suddenly you see this massive jump here. And so that means that there's been lots of different mutations that have formed this lineage B117, so the British variant. And this is extremely unusual. We haven't really seen that up till December of this year. And there's now extremely strong evidence that this variant transmits more than other strains of the virus. The good news is that there's no change in the severity of infection, so people there's no increased mortality, or it doesn't look like that, but still this is extremely bad news, because this means that there's a very high risk of the virus, viral spread of the virus spinning out of control very quickly, and which we have seen happening in the UK, which has led to this incredible spike in cases, and followed 2-3 weeks later with a spike in deaths. And I have to be very realistic here. So yesterday, I haven't seen today's figures, but yesterday 1,500 deaths were reported. And I think before the month is out, we will have days where there's more than 2,000 new deaths will be reported, because deaths are lagging behind the number of cases. the good news, another piece of good news is that vaccines still appear to work. And that's one of the reasons why I applaud the government's attempts at vaccinating as much as the population in a shorter period of time. And compared to other European countries, the UK is doing really well in this respect. But what we also have seen over the last few weeks or even days in the case of the new Brazil variant is that more of these variants of concern are appearing, and mostly they seem to be characterized by increased transmission, and there's so far not a lot of data to suggest. That's interesting. Big Guns N' Roses fan myself, but there's not a lot of evidence to suggest that the vaccine might actually change its efficacy against these new variants, or that there's a concern that they might be more virulent, so that they might cause more deaths. But of course, this is the big piece of news that happened recently since we last had this webinar. So I'll stop there, stop sharing my screen, and I think we can take some questions.
And you can ask anything. We'll do our best to answer it.
Yeah.
But we will try and avoid any kind of fake news and say it like it is.
Good. Right, let's get back. So from the beginning, we had a couple of comments from people about travel and no testing at the airports, but people told to quarantine. So guys, what's your feedback on that?
Don't get me started. I mean, I never understood this. If go back, I'll mention this before. I think I said this the last time. The day I realized this was going to be massive was when I read paper in the New England Journal of Medicine about talking about COVID-19, but also reflecting back on the previous pandemics, because I'd always been fascinated by the whole 1918 Spanish flu, and I knew that figure, 50 million dead. But the thing I didn't realize was only 2% mortality. And I thought, oh, hold on, only 2% mortality. Bloody hell. That clearly COVID was going to be massive. And that was, February. So, and if you go back to then, anytime you put lots of people in a large metal box, okay, whether that's a ship, and that's what happened in Spanish flu, or an aeroplane, okay, you're going to get a spread of, that's my basic, apologies, Willem, my basic microbiological knowledge, people in close space, it spreads, okay? And I don't think actually I've heard a healthy debate about what happens next, because I think it's going to be a real challenge for the travel industry moving next, and how we, because we keep thinking, well, we need to get vaccinated in the UK, but actually we need to think about the world in a sense. How do we vaccinate everywhere else? How do we organize travel to other countries which maybe haven't got vaccination? How do you have quarantine with that? And and just the way we manage things is I just find it incredible. In fact, just today, a friend of mine is flying off to Australia. Okay, she's Australian. Okay, it's a different planet there. She has to go to a quarantine hotel for a couple of weeks before she gets to see her parents. Yeah. And that just hasn't been looked at. And we're more focused on people in dinghies than people going through airports.
Let's say if I look at the question, it's also about the situation in spring. So I think back then there wasn't a lot of testing availability, so that was still a sort of limitation then, why you would be unable to test everybody who would be arriving at all the international airports in the UK. I think in retrospect they should have been, of course, they could have followed the Australian strategy, which is to quarantine people for 2 weeks in a hotel. But that's very much with 2020 hindsight, no pun intended about last year, but because that is, no European country did that in the end. So I think that Australia is sort of able to do it because it's pretty isolated from the rest of the world. But if European countries are so interconnected, even in the times of Brexit, that it's just going to be very difficult to do that. What I think is something that, so I would give I have some understanding why maybe that didn't happen in March and April. Why then it's taking so long to implement something like more testing or clearer quarantine or implementation of quarantine, that is beyond me. So I traveled back to the Netherlands in September when COVID cases were very low because of a health issue with one of my parents. So I wore a mask, etc., etc. I didn't go out for 2 weeks. And I was expecting to be checked at some point, that at least somebody would call me up and ask, are you staying inside? But nothing. I was not checked at all. And I think, and everybody knew that, right? I was on a plane with basically people just planning where they were going to go fishing the next day. And it's just, and I think that everybody knew that, let's say, that those guidelines were not being followed. And so that should have been implemented. And right now, and then I'll shut up about travel. Right now, there is rapid testing is being implemented at a number of airports, and of course that will filter out the most the most extreme cases, or people that have high levels of the virus in their throat, and of course, that's a good thing because they're very likely to spread the virus. But these rapid tests are not very good at picking up people that have lower levels of virus. And there's now just yesterday, I think, yeah, that's one of them. Is that the Innova
That's
one?
my lateral flow test.
Yeah, yeah.
I thought I'd bring it for amusement.
Yeah. And so just today or yesterday, there was a paper that was published which showed that even if you test everybody and then put people for 16 hours in a metal tube by flying from Dubai to Auckland, then you still get transmission within a plane, because you can miss somebody with these rapid tests, and they will infect people during the plane voyage. And of course, people in New Zealand have been incredibly good in checking this. They were able to do that. Sorry, can I just one more minor round?
By all means.
It also, this all starts and ends with test, trace, and isolate, and we don't have to revisit that because right now the number of cases are so incredibly high that we would not even, with the most efficient system, that we would be able to test, trace, and isolate those people that have come into contact with patients. But yeah, well, I'm trying to stay diplomatic here, but at least the billions that have been put into this, we should have had a sort of system that was up and running by September, October time. And if we would, then we would not have been in this situation right now, I'm sure. Sorry, David.
Which in a sense is why I cannot actually put into words just how difficult the situation. This is absolutely not like any other NHS winter. I mean, this week, every single day, I've seen something get worse. Okay, and it's really very difficult. You know, I'm a neurologist. Okay, so I'm not a surgeon. Okay, yesterday I had to go to an operating theatre. Okay, that's because that's where the ventilator was. Okay, that indicates just the strain there is on intensive care across now. I think it's difficult. You've got to bear in mind, and you know, most people who get COVID-19 will get through it, okay? And in a sense, I'm not the person you want to see, because if you're seeing a neurologist and you've got COVID, usually something catastrophic's happened. That's a tiny, tiny, tiny minority. But it leads into what Willem is saying, and you know, I think the vaccination is so important, and getting, I think, healthcare staff vaccinated as soon as possible is a real priority, because we know that the vaccine reduces sickness and reduces death, basically. So my worry is getting as many people vaccinated as possible. In fact, just conversation I had yesterday in the queue for coffee, okay, because we're all wearing scrubs, so we all look the same. I was chatting with Anthony, who's the guy that runs a coffee shop in the hospital where everyone knows him, okay? And I just said, and I say, have you been vaccinated? So, all right, Dr. Nicholl, I've been vaccinated because I'm thinking, you know, he's got lots of contacts. And the woman next was a Afro-Caribbean clean domestic, okay? And I said, have you been vaccinated? Oh, no, I wasn't sure about that. And I said, oh, please, 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 you must, okay? If I could give you my second vaccine now, I would, okay? Because you really are more at risk than me, you know, and I think there's a real challenge to challenge, you know, people have got questions about the vaccines, which are understandable. People worry about, you know, it came out so fast, but I think, you know, it's a fantastic piece of science. But, you know, honestly, if you get a text or a call to be vaccinated, honestly, it was 2 o'clock in the morning in Aberdeen, I would go to Aberdeen, okay? It won't be in Aberdeen.
You know, David,
okay?
I think you're probably preaching to the converted on this call, I'm going to say. And anyone who feels otherwise is welcome to say in the chat. It's probably a very brave thing to say, but you're welcome, and you probably will be challenged.
If people have questions about the vaccine,
exactly.
Yeah.
Well, look, guys, you've been quite chatty on that one, so you might need to be a bit more succinct on the other ones. Now, before we go to the next question, Richard, I've seen your question, which is what's the most sustainable way of managing COVID-19? But would you mind just reposting that with a bit more detail? Because I'm not sure what you mean by sustainable there, the guys might, but if you can do that, we'll make sure we answer that correctly. Now, whilst we're on the vaccine then, Willem, I think you said you're a fan of the new way of doing lots of people once first, but perhaps you can explain at what point that becomes, or explain your thoughts on that. You know, should people have it done within a certain amount of time? Is there anyone who really should make sure they have two? What's your view?
So, this is the subject of intensive debate. And so in an ideal world, you would want to give somebody a jab, and then, and I have to think, I think it's 3 weeks later, that's when you give people a second jab. And that has been tested in those beautiful trials that have been done in the second half of 2020. And we know then that's how the vaccine works. That is, however, really difficult, because that means that if you want to vaccinate a certain number of people, let's say, sort of a continuous number of people every day, that after 3 weeks, suddenly that number goes up twofold. So you suddenly have 2 times as many people coming in, half of them for their first vaccination and the other half for the second vaccination. And that's complicated. There's a very complicated logistics involved. So for that reason, many countries, not just the UK, are now saying, okay, we're going to delay that a little bit. So we're going to give people a first jab, which we know is pretty protective. And then we're going to give that second jab as quickly as possible, but it might take 3 months. I don't think that there is a consensus on whether, I think the consensus is, generally speaking, in a country like the UK, where the number of cases is so high, that is probably a good strategy. If you, for logistic reasons, you can't give that second jab after 3 weeks, because then you start to protect most of the population, or the highest number of people in the population, in the shortest possible period of time. The only risk that you have, and that is something that basically nobody knows, is that you will have something which is called vaccine escape. So that there will be a mutation in the virus, maybe other mutations than I've talked about in my presentation, that will, to which the vaccine is not that effective anymore. And that's a risk that we are taking by extending that period of time between the first and the second jab. I think on balance, let's say having as many people as possible have that first jab is certainly from public health reasons is probably a good strategy. But I wouldn't want the government to think, okay, we've given everybody the first jab, we can give that second jab in 6 months. We need to keep them on their toes, as it were, and we need to say, okay, that second jab needs to be as close to 3 weeks after the first jab as possible.
3 weeks? Or
yeah,
3 months?
I think, and that might change. There might even be different between Pfizer and Moderna and AstraZeneca. So I probably should have looked it up before, but there is variation there, possible variation between the different vaccines.
Yeah, I mean, there's an intense debate. The particularly Pfizer one is meant to be at 21 days, and I've been doing a lot of work with the Doctors Association, and certainly the GPs I speak to are infuriated by the idea of delaying that because of the issues of consent, which is really important thing as a doctor in terms of if you're consenting someone to have an injection in 3 weeks and you suddenly change that, that's a bit of an issue, okay? But I guess the public health view on that is that, you know, we are in a absolute public health crisis. I mean, you've seen that curve going up, okay? And you want to protect, like that cleaner I met in the coffee queue and everyone else. So you want all those people to get at least their first jab given, you know, and the kind of peak we're talking about, certainly that I've been hearing is maybe certainly in Birmingham towards the end of January. We're really, really, really worried about the NHS being overwhelmed. And, you know, if I look, you know, the UK has got half the number of ITU beds as somewhere like Italy. And conversely, the way we're managing COVID is very different to the way we did in the first wave, because there's a lot of very, very sick patients on medical wards having what in normal circumstances would be intensive care. So, you know, I am super anxious, okay?
So can I, maybe, I saw one question on the chat, and maybe we can do that right now. And that is about, somebody is asking, because they got a bad reaction to a tetanus jab when they had a, well, 2 decades ago, 3 decades even. And whether, and that is a cause for concern, right? If you had a bad response to a vaccine, and whether that should, basically what we think about that. Can we reassure this person? David, do you want to? I can. I mean,
I think the main worry is actually people have severe allergies. So if you need to use an EpiPen, okay, that is basically a no-no, or speak to someone. In fact, I've got a colleague who has an EpiPen who wants to have the vaccine, and she's having to speak to her immunologist about that, okay? But that's a very unusual circumstance. So just having a reaction to another vaccine, it would not be a contraindication, basically. So, you know, it's a good question, but there really should not be any risk. Obviously, it also depends on your age as well. I mean, we know, and that's why the targeting has been for the elderly primarily, because they're greatest at risk, and gradually going down to everyone else, basically, because those, you know, basically the older you are, the greater risk of death or hospitalization. What I haven't worked out in the maths, you know, if you were to vaccinate a child, well, their risk from COVID may be actually quite small. But the reason for doing that would be to try and reduce infection. And we don't know the answer to that yet. We don't know if the vaccine actually reduces infections to other people. It probably does, but we don't know, which I think was another question in the chat.
Thank you. Now, guys, you'll notice in the chat, I'm going to the very last question, but it was Richard's, and he's rephrased it for me, but he was high up the list, so forgive me for that. So Richard asked, locking down and opening up is surely not the most sustainable approach to dealing with COVID-19, either with regards to health implications or the economy. So what's the most sustainable way of dealing with COVID?
It's a really good question. And actually doing lockdown in January is very tough, because the natural history of a coronavirus, you're going to get a peak in the winter. So trying to do it is like the worst possible time to have to do it, but we had no other choice, basically. What I would say is, if you actually look at our response and why it's been so bad, it's basically because we dithered so many times, if I'm honest. And, you know, those countries, and not just the UK, but actually, you know, Europe has not managed this as well as countries in Asia. And I suspect that's probably because countries in Asia had the experience of SARS. So they closed down things real hard right at the beginning, but actually avoided some of the lockdowns. So countries like South Korea have largely avoided lockdown to some extent, because they had a proper track, trace, isolate support system. And it makes a big difference. And you basically, you know, you can't have wealth without health. And my real worry, and all of us worry, is the non-COVID effects, and the stories you've heard in the news about transplant program being delayed in Birmingham and things like that, and patients not having their cancer sorted. But, you know, it's a bit like the story I was saying about, you know, you need an operating theatre to treat the cancer. Well, you need a ventilator to manage the patient with COVID. And that patient with cancer needs to be treated infection-free. So ideally, we need to suppress the virus right down. I think the mistake we made in the summer, if you go back July 4th, which I can remember the Sun had as our Independence Day because we were coming out of lockdown. Well, actually, we were still having 600 cases a day, and we didn't have the track trace. We absolutely had nothing sorted in terms of track and trace then. And I think the Eat Out to Help Out will have proven to be an abject disaster. And we are where we are, basically. And I find it really makes me angry, actually, when I think back to the decisions that SAGE recommended about closing down in September, which were ignored. So actually, we've never followed the science, never. But then I guess it's ultimately, the title of this talk is Politics and Pandemics. Ultimately, it will always be a political decision. I just think the political decisions have been lamentable. They've been so slow.
To add to that, what I think is also problematic in the UK's response is that there does not seem to be a middle way between lockdown and opening up society. And so we had a sort of mild lockdown in November, which was pretty successful. Cases went down. And so what the government then did is basically on the 2nd of December, they said, okay, lockdown is finishing, particularly in the Southeast. I think Birmingham at that time was still in tier 3. Basically, because I can't remember anymore, which basically illustrates how poorly thought through that tier system was to begin with. But basically, they made it very complicated, and they opened up both restaurants and schools and non-essential shopping. And the thing that you need to do, and that I would hope that they do next time, if we see that this decrease in cases, then first you open schools, because we all agree that closing schools is the last thing that you should be doing. And then if we reopen schools and we don't see an increase in the number of cases, then we think about reopening hospitality. And so in that way, we can basically have a much more gradual idea of what is happening on the ground, rather than basically going from lockdown to opening up again. And again, I sound like a broken record, but test, trace, isolate, that needs to function if you start opening up again.
And support. I think that's important. I mean, I was at a GP surgery in Soho Road in Birmingham. So Handsworth, very impoverished area. They've got cases, that's COVID central in Birmingham. Okay, so there's over 1,000 cases, 100,000 there. But if you go along it, it's a very crowded area, multi-generational households. In fact, the whole story about COVID is about poverty. And actually, I would say the challenge coming out of this is actually how are we going to deal with poverty, actually, because it's, the most vulnerable in society have been absolutely ravished by this. And is that actually something that's going to be acceptable? And it was a very good discussion about on the Today program, thinking about how we built the welfare state actually during the war, not after the war. Actually, I think that's a challenge for us, is where we go next. Is this really acceptable, the way we failed, actually? In fact, this was a failure of defense. The first rule of government is defense of the people. And we were worried about a bunch of dinghies, but we weren't worried about a virus coming in through the airports.
I'm going to move on to the next question. You're very chatty tonight, guys. I'm getting the feeling that this is a bit like therapy, and might be helping you a little.
I mean, it should be helping everyone else.
So we talked very briefly before we came on about the fact that actually the behavioural scientists are saying that actually 80 to 90% of people are following the rules. So there's this sort of, so people are thinking, well, who are these 10% that are breaking the rules? Now, can you put us straight? Where is this coming from? Where are all these new cases coming from? Why is it spreading so rapidly? Basically, are we paying now for Christmas, or was this always going to happen with the second spike?
I'm going to speculate a little bit here. So even if you follow the rules, it doesn't mean that you're basically that's the problem, right? If you're in a supermarket and you wear a mask, but somebody next to you isn't wearing a mask, or isn't well, let's say is not wearing a mask, and that person is COVID positive, even though you are following the rules, that person will may infect you. And I think we've seen a lot of, at least anecdotal reports right now, that there's been a lot of COVID transmission in supermarkets in the run-up to Christmas, because it was busy and people were stressed and they wanted to get the shopping done, etc., etc. So even that 80 or 90% of the population that is strictly following the rules, sometimes you still have to engage with other people, and that is always a risk, because and even if everybody in a shop wears a mask, that's not 100% protection. That can still, the virus can still escape from that, and that's the difficult thing with this new variant. The reason why it transmits easier is presumably because the people that are infected with this variant have 2 to 4 times more virus in their throat. So even if they breathe or if they talk, and particularly if they cough or sneeze, they will expel those viral particles like we all do, but it will just be more. So the risk of infecting people is higher.
And I think your point about behavioural change is really important, actually, because I think there's always been a natural tendency of, I don't know, tabloid media. Well, like the story about Boris going on his cycle, okay, which went on for ages, but it was actually very tedious, okay. You know, I'm not Boris Johnson's friend, but I don't think, you know, I don't think that was a useful story at all, basically. And, you know, there's a kind of natural British tabloid tendency to point the finger and say, you know, and there was one of the people from SAGE, behavioral scientists, and I mean, it's very interesting. It was actually, there should be more stories about the people actually doing things properly, because the risk is that people think, oh, well, he's not doing it, then why should I? Okay, which actually just deconstructs the whole thing. And, you know, I think it's very hard for us, in effect, as liberals in a liberal society, following the rules, whereas you know, countries like Taiwan, South Korea, Japan, there is a much greater acceptance for following those kind of behavioral change, and it's a real challenge. I mean, I don't like wearing a mask, but you know, you got to do what you got to do, basically. But and you know, I don't know if I answered the question, but it almost, we need to go through a society change in the same way it's unacceptable to be driving a car and smoking a cigarette with the kids in the back, okay, or driving without a seatbelt. So it's not just about the law; it's about it being socially unacceptable, but we're also recognizing that, you know, if someone's got dementia or severe learning disabilities, then maybe managing a mask is a difficult thing.
Yes, or my friend's got a deaf child, actually, so she needs him to be able to lip read. I'm going to say that on her behalf, because I think she struggled with that a little bit. Right, so we've got some really good questions. Claire, thank you for your question, because she appropriately, she's talked about supermarkets as well being a bit more of a risk, and she's asked about whether this new variant spreads more easily on surfaces than before. And we've talked about this. This has been a thread throughout. So can you tell us what you think about that? Does it spread more readily on surfaces?
I think the vast majority of infections are by the respiratory route, so by breathing in the virus. There might be some transmission on surfaces, but it is limited compared to respiratory transmission. That's not the thing that I would be worrying about when I'm in a supermarket, that I would, let's say, touch an orange that might have been touched by somebody with COVID. It is really breathing in viral particles in places where other people are around.
And the airborne route.
Sorry, because you might want to answer this bit as well. If people are critically vulnerable, should they consider just wearing gloves when they go out? Perhaps you can incorporate that into your answers too.
I actually think the mask, this is an airborne disease. And we talked a lot about fomites, you know, stuff being picked up, but I think the airborne aspect is much more important. Yeah. And, you know, wearing a visor is actually not as good as wearing a mask. So, you know, you see people wearing the visors and think, well, actually all you're doing is just directing it downwards. And it's a massive challenge within hospitals, thinking about ventilation and how you manage it. Yeah. So distancing helps. There's been some debate with this new variant whether we should distance more, potentially, is one debate, if it's more transmissible. There's also debate within the medical profession about, you may have heard of the news, BMA and Doctors Association, others calling that we need a higher grade of PPE, potentially, given that this is more transmissible. So I would focus on it being an airborne disease, which the WHO were criticised for being very slow for recognising that.
Yeah, I mean, you've mentioned poverty has come up again countless times with this. I have wondered lately whether the fact that people have to go and pay for this PPE, and it isn't necessarily cheap. You could argue you buy one and you wash it all the time, but they're very easy to lose. But actually, you know, if you're really struggling on a low wage, then a couple of pounds on masks is a bit of an ask, actually. Should some people get these for free?
Absolutely. I mean, I think this. There's also debate about COVID in prisons and things like that. You actually need to look at the most vulnerable in society. This virus loves the poorest, most vulnerable in society, basically. And it's, you know, unless we protect everyone, we're all at risk. Yeah.
Yeah. Actually, I like that you raised that point. If it can link to that. So one of so prisons are really now, let's say, the ground zero of COVID-19 spread in this country, in the southeast, but also next to Bromsgrove, there's a prison on the way to Redditch, and levels of COVID-19 transmission are incredibly high there. And this may make me very unpopular, but I think those prisoners and the people that are working in a prison need to be vaccinated, because they need to be protected. They're in prison, but they're not condemned to die of a respiratory disease. And we do need to protect them, and we need to protect the people that the prison guards, essentially, that obviously have to work with these prisoners. So prisons are maybe an underestimated sort of vector as a source for these infections.
I think that hasn't been something I've even read up on much, and I think that's a really interesting point, Willem. Thank you. I'm trying to find our next question because we've got plenty of them. I'm tempted to, I'm not going to ask this, but I'm tempted to ask you Mark's rhetorical one, which is why can't Boris see the blindingly obvious, but I think we'll leave that one for another day. Phil asked, I'm hearing more and more about airborne transmission. Should we be putting more emphasis on ventilation of outdoor spaces to make them truly COVID secure?
Well, I'm not an expert in ventilation, but I just hear it all the time about ventilation. I think it's going to be, it's a challenge throughout, basically. Obviously, I'm aware of the hospital sector, but it's, you know, I don't think we can emphasize it enough, basically. And, you know, that is definitely going to be a problem, even just thinking about the hospitality sector. I know, you know, the term COVID secure, I mean, you can mitigate, but you can't remove the risk completely, and which is why vaccination is so important. But being outside is obviously less of a risk, but being outside in a crowd, there's going to be more of a risk. So just the closer you are to someone, the greater the risk, basically. And which is also, with hospital-acquired COVID, that's why I get a bit irritated, because you can't move the risk to healthcare professionals. My office this is my office at home, but my office at work is not much bigger. So if someone else comes in, I'm immediately breaking the rules of social distancing, obviously wearing masks, but you know, you can lower the risk, you can't remove it completely.
Okay. So Nigel asked, why is golf still banned now? I think I can answer this because it's still due to the lockdown. But actually, Nigel, the golf courses were opened before we went into lockdown. They were open for quite some time. So I think that's lockdown related. I don't know if there's anything you want to add on golf courses. Of course, you would need to go indoors, which is an absolute no-go with other people right now. So.
But I see the point. I mean, I think the risk from golf has got to be pretty small.
Yeah.
Yeah.
Unless it's me playing, because I would keep whacking.
I think it's the, let's say, going inside bit of golf before or after that is the tricky bit here.
Yeah. Possibly I mean, you know, temptation to be closer than I mean, you still walk around together, don't you, and stop and chat and things, which Yes, yeah. Sorry,
Well,
Nigel. I think if we can't do other things, I'm in favour of golf being banned. My apologies. Now, Mark Smith, do we know? We've already talked about this a little bit, but I'm going to pick this up anyway. Do we know that vaccinated people cannot spread the virus? Now, he's added Japan introduced thermal cameras to check people's temperatures at arrival points in ports and airports with SARS. Has been there ever since, and the technology was already around. And we already know, I mean, Japan, which has got a very elderly population, actually has had a much better pandemic than us. So what do you want to say about that?
So first of all, I can try to be very quick here. The thermal cameras don't really work. They will not pick out everybody who's positive. It won't pick out the people that spread asymptomatically. So I think that's a bit of COVID theater that some countries are doing in terms of trying to stop the spread of the virus. What's the other point again? The one was about thermal cameras.
Thermal cameras checking people's temperatures at arrival in ports and airports for SARS, and it's been around ever since. But I think that the point is that actually Japan haven't had it hard, have they, this time? They've, I think the Princess cruise was off their shores and was this petri dish of COVID, but actually Japan itself has done pretty well.
Whether that's behavioural change, there's more of a acceptance of wearing masks even before this happened in Japan. If there's flu and things, I'd be interested just on genetics, whether that might be a factor. I don't know. It certainly can be. Genetics can be an effect on the severity of COVID, but I don't know. But if you just look at Asia, they've done miles better than Europe. It's not all New Zealand. Taiwan has had a total of 7 deaths in total. Incredible. Okay. You just look at all the things they've done, and actually behavioural change. My favourite story about Taiwan, I think I may have mentioned, was that the government has a civil servant who works on fake news. So there was going to be a run on toilet paper, so they created a meme of a picture of the buttocks of the Prime Minister of Taiwan, and that went viral, and everybody laughed, and no one went out and bought toilet paper. I'm not for 1 minute suggesting there should be a photograph of Boris Johnson's buttocks, but.
So I look back on the question that Mark asked. So his first question was about whether vaccinated people can still spread the virus. I think the short answer is we don't know yet, and the slightly longer answer is there are indications that transmission will be lower in people that are vaccinated, but we don't have the full answer to that yet.
Okay. Judy asked a good question, which is for travel purposes, do we get a certificate for vaccination? And I think that's, I think added to that, people are thinking, should countries be ensuring or insisting that people get vaccinated? So yes, but Judy's question is, do we get a certificate of vaccination? Perhaps you can answer that for us.
I don't think you do. And I noticed Ryanair in their advertising had a jab and go as part of the advertising, which I thought was so misleading. I actually reported on the Advertising Standards Authority. I haven't heard back yet. So we don't know yet, but there's been very little debate about what's going to happen. I think just because we're all in the middle of this, and I'm going back to what I said at the beginning. It's important to say we're uncertain when we're uncertain.
Yeah. Okay. Nigel's asked about the risks on planes and how high they are, and should planes be internally redesigned to give passengers some sort of cubicle?
I think it's a real challenge, actually, that, you think of the trillions of pounds this has cost, is actually how we're going to need to rethink international travel, because the risk of pandemics is not going to go away, basically. And it's, I'm sorry, I'm answering your question with a question, but we are going to think, and we've known this for years with international travel. It's very easy for a virus to spread within, less than a day across the world, basically. And if you just look at the appalling effect that this pandemic has caused, and how do we plan for the next one? And that, I think, is investing in public health, thinking about all the things, learning from the way countries like, areas like Asia have managed well, and learn from those so we do things properly the next time. Sorry.
Well, you always say you'll tell the truth, and I think that's what people appreciate when they're coming on here. David Warren's point about people in insecure employment is a really important one. Now, he hasn't phrased this as a question. He's been talking about people being forced to work, and some have died as a result of COVID. And we know this to be the case, that people, even though they perhaps know they should be isolating, if they are taxi drivers or gig economy workers, or people on very low salaries, and actually losing that 2 weeks of pay is something they absolutely cannot do, and so they are having to go out to work knowing they might be risking the virus. We can't really put the blame on them, can we, if there's no support network?
No, we shouldn't. No,
blame doesn't
not.
work in a pandemic. It really doesn't. And unless you support the most vulnerable, whether it's prisons or people or homeless or whatever, your strategy is going to fail. And if you look at the number of people that isolate, that's why track and trace hasn't worked. The last time I figured it was about 20-30%, if not lower, that actually followed through it. But they've got to be supported. Not all of us can work from home.
No.
Absolutely. I think we've pretty much, actually, we're on the button, which is astonishing. We've pretty much covered all of the questions off. Sometimes you've answered them in advance, which has been excellent. So thank you so much, chaps, for doing that this evening. It's been really interesting as ever. And thank you so much to all of you, our contributors, for your comments and your questions. Again, we've had a really great range of things today, so I'm very, very grateful for all of your input. We've come to the end of this evening, so if you want to put any words of thanks in for our wonderful panel, then I'm sure they'll be grateful to have that feedback from you. And of course, as we mentioned at the very beginning, please do tweet #WMLibDems. Follow the two good gents here to hear more from them on a daily basis. And I think we will hopefully, we will see you again at some point, and hopefully at that point we'll be on the way out. What do you think, David? Will we be on the way out next time we do this?
My prediction, we're talking about next month?
Should we say mid-Feb? Where are we going to be in mid-Feb?
Still fairly rocky, but beginning to come out. Okay, yeah. But it's still, when I think back, gosh, I reflect back in March, I'm appalled there's no national strategy on what to do when we run out of kit. Okay, it just seems to be leaving to individual hospitals. So, I've set up a clinical ethics WhatsApp group yesterday. It's just, where's the national strategy?
Yeah.
Anyway, I'll let you know if we get through it in February. I think we will, but I really worry for my younger colleagues. That's what I'm.
Yeah, I think things will get worse this month in terms of the number of people dying of COVID. Certainly by the end of this month, we should see a clear drop in the number of cases. And so that around that time, by the end of this month, hopefully the pressure on the NHS will be a little bit lower. But yeah, so it's going to be a really bad 4 weeks. But I think when we see each other again in 4 weeks, we can be a bit more optimistic about the next few months.
Nigel's comment is actually the wisest one. Actually, just make sure to take time still in your life. And honestly, yeah, it's true, because I think it can do your head in. I think actually nationally we've all got a form of PTSD to some level or other, and actually just taking a break is a good idea. But also actually just speaking to your wider team. So I tried to speak to some of my colleagues and things like that. I think it's so important just psychologically to keep yourself going.
You're absolutely right. Thank you, Nigel, for those words. They were wise words to end on. And I think in the middle of the pandemic, we wanted some hope, and you've given us some cheery words there. So thank you so much. Okay.
The vaccine is coming.
The vaccine is coming. Okay. Well, thank you very much all for participating, and we hope to see you next time.
Cheers. Thank you.
Cheers.
Thank you.